from several decades ago now, but they examined the relatively rapid desegregation of hospitals in Mississippi on black infant mortality rates. So this isn't even really a difference in differences design in the sense that they don't really have a control group here. This is more just like before, so prior to sort of civil rights legislation, the hospitals in Mississippi were all segregated. So it was like there was a hospital for white people, there was a hospital for black people. I don't know if they even made a claim that they were separate but equal at that point, but they certainly were not equal, that's for sure. And so then like the federal government basically stepped in during like the 1960s and said like, look, you have to desegregate and just have hospitals that are hospitals, not for specific races. And so this essentially should improve the healthcare services that are available to black people in a relatively short period of time. And so ideally you might sort of want another area that didn't have this policy change during the 1960s, but those don't really exist because sort of the entire South was being desegregated at that point. So it's not even really a diff and diff. That being said, you can see just from the time series in infant mortality here that it looks pretty clear that there's a very large treatment effect, right? So the infant mortality rate for blacks is pretty stable during, this is the number of post-neonatal infant deaths due to diarrhea and pneumonia. It looks pretty stable from 1955 to 1965, and you can see it's also something like 7 times the rate for whites in Mississippi. Then in 1965, they're forced by the federal government to desegregate the hospitals, and you can see that it falls by something like 70% or something in just 5 years. So I think it's pretty strong evidence that access to better care in that case did improve outcomes for infants, although again, this is probably coming from a very low standard of care by sort of modern developed country standards. And so then the last sort of study I want to talk about in this context is this study from Oregon. So this is an actual randomized controlled trial that happened a few years ago. And what they did is basically Oregon, forget the exact institutional details, but basically they were going to expand like Medicare coverage, or sorry, not Medicare, Medicaid coverage in 2008, but they knew that they weren't going to be able to basically sort of meet the there was going to sort of be a shortfall in the coverage expansion relative to demand. So there were going to be sort of like a new set of people who were potentially eligible, but not everybody who was potentially eligible under the expansion was going to get covered at least in the first year, just because they didn't have the funding to roll out coverage to the entire potentially eligible population. So I don't know, I don't remember, or I don't know sort of what the details were in the negotiations and so forth, but a group of health economists basically got Oregon to agree to either do a lottery, or Oregon was already thinking of doing a lottery, and they got Oregon to agree to sort of allow them to use it as part of like a research experiment. But essentially what they did is they said, okay, we're going to expand sort of a new set of eligibility conditions that will make more people eligible than were before. We can't cover everybody, at least not immediately, who's going to be eligible under these new conditions. So if you want Medicaid and you meet these conditions, then you should sign up now. And then we're going to just do a random lottery, and some people will get it, and others won't. And presumably over time, like whatever they find more funding, then everybody eventually get to a point where they're actually able to cover everybody who's eligible under the new standards. But sort of in the interim period, you're going to lottery off access because you can't cover everybody, and that's sort of the fair way to do it, right? So they basically were running what amounted to a randomized controlled trial here, where the sample of people who were in the study were those who were signing up for Medicaid, who didn't already have it and were eligible under the new criteria. And if you won, then you were essentially treated with you were getting Medicaid, and if you lost, then you were sort of in a control group and you didn't get Medicaid. So they did a follow-up. They collected data 2 years later after these people had been assigned into the winner, winning, and losing groups, and then had time to make their healthcare decisions now that they were insured, or of course they remained presumably uninsured. And they sort of found a sort of mixture of things. So there was not any effect of getting health insurance coverage on hypertension, so whether or not you had high blood pressure, or on high cholesterol levels. So it's maybe a little bit disappointing in the sense that those are 2 conditions that are treatable, and you might be thinking that the people would not have been treated if they didn't have health insurance, and now they could afford to be treated, so maybe you find some effects there. They didn't find any effects. I don't know exactly what the power was. I mean, they had a pretty good sample size, but it will depend on sort of how common these diseases are in their actual population in terms of the statistical precision to detect effects there. There was a higher probability of diabetes diagnosis, so basically, I guess one possibility is that somehow getting health insurance would cause you to have diabetes. That seems very unlikely, although I'm sure University of Chicago economists could tell you a story about how before you didn't eat donuts because you were uninsured, but now you do. But I think that the more likely mechanism here is basically just you're going to the doctor more often now that you have health insurance, and they test your blood glucose levels and so forth, and detect that you have diabetes, and then you start to get treated. So definitely if somebody has diabetes, like you want to diagnose that and start them on a treatment plan. So it's good. This is I would interpret this as a good outcome that they are in fact diagnosing more people with diabetes. The thing that tempers this finding though is that there's no effect on glycated hemoglobin levels. So basically this is like this is a marker in the blood that they're trying to control. So once they start diabetes treatment, this is something they're going to be targeting, and they want to make sure this doesn't go too high. And so if you're diagnosing these people who have diabetes and you're targeting this measure with your treatment plan, ideally you'd like to see it be lower, but you don't actually see that. And again, I don't know exactly how many people on the margin, how many extra people they were diagnosing with diabetes, but it's also probably true that probably the marginal person who's getting diagnosed here when they're insured but wouldn't have been diagnosed when they weren't insured probably is not like they're not going to be like as symptomatic as somebody who already would be diagnosed even without insurance, right? Just because like if you're doing really poorly even without insurance, you're probably more likely to go to the doctor and find out something's wrong with you. So maybe it's because it's you're getting sort of these marginal cases earlier on that you don't see as much effect on the treatment or of the treatment just because they're not sort of in as bad shape yet. There was a lower chance of a positive screening for depression, so basically you were like less likely to be clinically depressed if you were assigned to the Medicaid group as opposed to not getting Medicaid. The thing that's interesting about this is so that basically they found like improved measures of mental health and even improved sort of self-reported physical health, so people like reported feeling more physically healthy. The thing that's interesting is that if you actually look at, so they collected some of these measures, they collected them like pretty frequently. It wasn't just like the 2-year endpoint. They actually collected them shortly after the experiment started and then like in the middle and towards the end. And so for the self-reported measures of health, they actually found that those improved before there was any substantial increase in like the uptake of services, right? So what you want to think of is you start the experiment, you randomly assign some people to get health insurance, other people are in the control group. just because I randomly assigned health insurance to you on January 1st, say, it's unlikely that you're going to like run out to the doctor on January 2nd, right, and immediately go and start like getting healthcare services. I mean, it's possible, if something happened to you on January 2nd, you might do that, but that's going to be like a very small fraction of people. It's also possible that you would sort of been waiting in anticipation of getting health insurance, then you might get a few visits then as soon as people became insured. But for the most part, it's like you don't see, just because like the experiment starts on January 1st, you're covered on January 1st, you don't see like a big increase in healthcare utilization in those first few months. The thing that's interesting is that they were already asking people to rate their health, and so even in the like first month or two before they had actually used any additional healthcare services, they were already rating their health as better. So presumably what that means, it was more like sort of a mental thing of like you just weren't as kind of stressed out about the fact that you were uninsured and you were concerned about like if you did get sick then you might like, go bankrupt or something like that. So I mean, I'm not like potentially that in itself might have an impact on physical health, or it might just be that like just the fact that your life circumstances are better make you feel better about your health, even if you're not like clinically feeling any better or clinically better. Like you couldn't detect any differences in any of your like blood screening measures or anything we did. So I think that's sort of interesting. It's just sort of more like sort of like a mental health sort of aspect to it. And then they also found that there was an increased use of many preventative services, which is the type of thing that like in the short run isn't going to make a big difference in your health, but hopefully maybe in the longer run could have some impact. So that's something that you wouldn't necessarily expect to pick up like the clinical effects of even after say a 2-year period like this study. So I would say sort of a mixture. I mean, there was no one clinical measure that really jumped out as like improving a lot, but there's some suggestive stuff. So you could sort of, I mean, I guess you could kind of read it either way depending on how you felt in terms of whether or not this was having a substantial impact on improving people's health. Okay, so that's sort of the evidence on effects on what we call the extensive margin. So the extensive margin is whether or not you have any insurance at all, and then the intensive margin is whether or not, or sort of like how generous your health insurance is. And on the intensive margin, there's really not a lot of evidence that increased expenditures seem to improve health. So there's this Wenberg et al. Study that finds that there's a more than twofold difference in Medicare expenditures per enrollee across regions. So this is Medicare. Now we're talking about like health insurance for older people. Medicare is like it's very important for a number of reasons. So first of all, it is the case that if we didn't have it, I don't know what exactly would happen, but I think if we didn't have it, there would be like very strong political like push to reinstitute or something, just because it's not clear how people like above 65 would be insured then, right? Because if you're retired, you don't have health insurance through your employer anymore. If you tried to buy health insurance on the individual market at that age, it would be insanely expensive. I mean, I guess now that we have the ACA, maybe the adverse selection problem would be solved because people would essentially be an individual mandate where everybody had to buy it. But even sort of ignoring the adverse selection issues that we'll talk about later on, just the cost of covering people when they get above 65 is like really expensive, and people are not good about saving for retirement, so they just wouldn't have the financial resources. Potentially like you could think of sort of companies like providing health insurance for retirees, because they do that now to a limited extent. Like some companies, it's like if you retire at 60, you might still have insurance. You won't qualify for Medicare yet, and so you might have insurance through your company, basically, like in that sort of interim period between 60 and 65. But if they tried to do it for like, if we had sort of a company-based system where it's like instead of just having a pension, which is very rare these days, or like a 401k, you also had health insurance for, from the time you retired until you die. That would be incredibly expensive from the company's perspectives. So they would, they would view like hiring workers as being way more expensive now, and sort of this per head like tax that they would think of in terms of like cost of running benefits. And second of all, it frankly wouldn't be good for the workers either, just because you would have a high risk that the company goes out of business. That was like sort of a problem with like traditional pensions, is that you have a company that's supposed to pay for your retirement benefits for 30 years after you retire, and then the company goes out of business, and suddenly you don't have any benefits. There's sort of like this pension guarantee backstop by the government, but it doesn't cover it at like the full rate. And again, health insurance is super expensive once you get up to that age. So I don't think sort of a company-sponsored like plan or system would work well for covering people at retirement and beyond. So Medicare, even though when it was like passed in the 1960s, was so back then there was a lot of political opposition to it, because the government was not all that involved in healthcare before then, and this was like a huge expansion. Now you have like those crazy protesters who were saying like get the government out of my Medicare or whatever. Just like makes no sense whatsoever. And it's contradictory. So I think it's clearly something that is incredibly important. It's just that from a cost perspective, even though only a minority of people at any given point are covered by Medicare, because most the bulk of the population is not above 65, it has a huge. The total bill is still huge, just because the cost of coverage per person gets so high once you get up to that age. And it also it kind of sets the standard for like how hospitals get reimbursed. So since it's such a major player in the healthcare market, far bigger than any individual insurer. So even like a very large insurer is still small compared to Medicare. The amount that Medicare decides ultimately to pay for various procedures in hospitals and stuff is basically sort of the starting point for negotiations when insurers then go and talk to hospitals about how much they're going to pay. So it's hugely important, and it varies tremendously in terms of like how much actually gets spent per Medicare enrollee across different regions in the United States. So some regions cost twice as much as others. So I think like maybe Florida or something is really high. And you're saying, well, Florida has lots of retired people. That's true, but this is per enrollee. So this is already being normalized by the number of people who are actually enrolled in Medicare. So it's like twice as high in Florida than like Minnesota. So there's a lot of things that higher spending on Medicare per enrollee doesn't correlate with. So it doesn't seem to be related to more effective care. So the measure of effectiveness of care, so the standard measure, is basically looking at procedures or at sort of treatments that, given a person's diagnosis, should be standard care based on the best evidence in the medical literature, but may or may not actually get prescribed by the doctor or the physician who's treating the patient, right? So basically, things that should be standard care for a given diagnosis are underused to the same extent in both like locations, so both the places that spend a lot on Medicare and the places that spend not so much on Medicare. It also doesn't seem to correlate with more elective surgery, so surgery that's kind of viewed as being optional. That's kind of surprising, maybe. Like you would think that type of something that's elective would be the type of thing that would end up appearing more in the higher spending areas and less in the lower spending areas. So it's a little bit surprising, but probably good in the sense we're already doing too much surgery at the margin anyway. Unfortunately, it also doesn't seem to correlate with better health outcomes. So in terms of like clinical measures of health for the enrollees, they don't actually seem to be any better in the high spending areas than in the low spending areas. So again, you can sort of make some argument that, like, well, maybe those high-spending areas just, for whatever reason, happen to have, like, particularly unhealthy elderly people, and so we have to spend lots and lots of money to sort of just get them up to the same health status as the people in the lower-spending areas. And maybe there's a little bit of truth to that, but it sort of seems unlikely that there's, like, dramatic differences in population health among the elderly across these different areas, and that for whatever reason, like, the additional spending goes into raising the unhealthier population right back up to the exact health level of the healthier population. So it seems more likely that there's just not a big impact of the expenditures, the variation expenditures on health outcomes. Okay, so I think we're basically done today, and we will talk more about this on Wednesday. I guess also I'll probably post a new problem set in the next, either today or tomorrow.